Legg-Calve-Perthes Disease. Idiopathic, avascular necrosis of the proximal femoral epiphysis in children. Repeated subclinical trauma, coagulopathy, maternal and passive smoking aggravates. 4 to 8 years is most common age. Male to female ratio is 5:1. Lateral pillar ossification. Based on the height of the lateral pillar of the capital femoral epiphysis on AP, imaging of the pelvi. Designed to provide prognostic information. Waldenstrom classification. Stages of Legg-Calve-Perthes. Initial fragmentation, reossification, healing or remodeling. Catteral Calssification based on degree of head involvement. Head at risk signs that are associated with poor outcomes. Gage sign, V-shaped radiolucency in the lateral portion of the epiphysis or adjacent metaphysis. Ossification lateral to the epiphysis. Metaphyseal cyst. Lateral subluxation of the femoral head. Horizontal proximal femoral physis. Salter-Thompson classification based on radiographic crescent sign. Crescent sign represents a subchondral fracture. Stulberg ossification, gold standard for rating residual femoral head deformity and joint congruence. Painless limb or intermittent hip, knee, groin or thigh pain. Physical examination, hip stiffness, loss of internal rotation and abduction. Gait disturbance, antalgic limb, Trendelenburg gait, head collapse leads to decreased tension of abductors. Limb length discrepancy is a late finding. Hip adduction contracture can exacerbate the apparent LLD. Early findings include medial joint space widening from less ossification of head. Differential diagnosis, radiographic differential diagnosis, infectious etiology, septic arthritis, osteomyelitis, pericapsular pyomyositis, transient synovitis, multiple epiphyseal dysplasia, spondyloepiphyseal dysplasia, sickle cell anemia, sickle cell disease, Gaucher disease, hypothyroidism, Meyer's dysplasia. Resolution of symptoms, NSAIDs, traction, crutches. Restoration of range of motion, physical therapy may exacerbate symptoms. Muscle strengthening, Petri casting, containment of hip, improve range of motion, bracing, proximal femoral osteotomy, pelvic osteotomy, ensure that femoral head is well seated in acetabulum. Lateral pillar involvement, children less than 8 years of age. Observation alone, activity restriction and physical therapy, ROM exercises until reossification is complete. All patients require periodic clinical and radiographic follow-up until completion of disease process. 60% do not require operative intervention. Good outcomes associated with lateral pillar A and Catteral 1 groups. Children less than 8 years of age, especially lateral pillars B and C. Studies suggest earlier surgery before femoral head deformity develops may be best. Poor outcomes for lateral pillar C regardless of treatment. Proximal femoral varus osteotomy to provide containment. Pelvic osteotomy, Salter or triple innominate osteotomy, shelf arthroplasty may be performed to prevent lateral subluxation and resultant lateral epiphyseal overgrowth. Complications, femoral head deformity, coxa magna, widened femoral head, coxa plana, flattened femoral head, lateral hip subluxation, extrusion associated with poor prognosis can lead to hinge abduction, premature physical arrest, trochanteric overgrowth, coxa brava, shortened femoral neck, leg, leg length discrepancy typical mild, acetabular dysplasia, poor development secondary to deformed femoral head can alter hip congruency, labral injury due to second to femoral head deformity, femoroacetabular impingement, osteochondritis dissecans can lead to loose fragments, degenerative arthritis, Stulbach 1 and most Stulbach 2 hips perform well for the lifetime of the patient.